Yeah, so I just want to check that we have until 2 o'clock Atlantic time. Is that correct for this?
Yep.
Okay, great. So hello, everyone. I know some of the people on this call, but not everybody. Nice to see Kathy again. Thank you for inviting me to speak at this series. I know there are some people from Dalhousie, and I do give talks on this topic very frequently for a variety of different audiences. I'm actually giving this talk to internal medicine residents on this coming Monday or Tuesday. So people, if you think you may have heard this talk before, it's possible that you have. But hopefully it will still be relevant and interesting. And if you have questions, certainly feel free to ask as we go along. You can type in the chat, maybe might be the easiest. And then Terry has an interactive exercise at the end. Terry, you just disappeared there, but did you pre-circulate your document?
Yes.
Yes. Okay. All right. So there'll be some time at the end to work on. I can't actually hear you, Terry.
I did. It's a one-page document, so all the residents should have gotten that. Tyson, I see you. Did you get that? Yes. Okay.
Yes,
so
I did.
Everybody did. Okay. Thanks.
All right. So this is the objectives for the session, and these were something that I guess is apparently one of the deliverables, or not deliverables, one of the EPAs for the geriatric psychiatry program. But I think it's very relevant for anybody who is going to be in practice, which is everybody here, hopefully. So we're going to talk a little bit about the rationale for continuing professional development as being a core element of your future practice, and also what the Royal College Maintenance of Certification program is. I'm making the assumption everyone here is in a psychiatry or some specialty that's Royal College accredited. The requirements are a bit different for family physicians. There's different elements of the framework that's used in the maintenance of certification. I'll be going over that and some of the activities. And also, I don't know if people know this, but by the time you're in your final years, I'm not sure if it's 5 and 6, but your final year anyway of your training, you can start recording the activities that you do in your training as part of your cycle for your CPD. If you're going to be working in a location where there's sort of an academic center and grand rounds and different accredited activities, it may not be difficult to get the credits, but a lot of people end up in areas where they do have to pay for conferences and other activities to get their CPD accreditation points. So if you're in your final year and you're getting them anyway because you're attending sessions that would be eligible, you might want to start recording them at this stage of training. Where's my, okay. This is an overview of what the session will be like. So in the first part, we will be talking about Mainport, as I mentioned, and its benefits. And then the second part will be developing a personal development plan. And this is the one that Terry will be taking the lead for.
And so Lara, that somebody had said, Harry had said the slides aren't advancing. I don't see the second slide there.
Really? All right, let's see. I'm going to stop sharing and try again. I wonder why that happened. What does it say now?
What do you think for the next 20 years? Yeah, so it did advance. Yeah.
What does this say now?
That's a different slide. Session overview.
Session overview. Okay. All right. And this should be the right one. So maybe I'll just ask for, let's say, 2 people to provide some suggestions of what you think is going to happen in psychiatry in the next 20 years that you think is going to be different from what it's like now.
For one thing, psychedelics research is being really expanded on, and our patients are asking more and more about it. So far, it's research, and we can kind of hide behind that. But eventually, I think this will be questions we need to actually, give a lot of thought into. Yeah,
I completely agree. Psychedelics were something that when I was training, so I finished residency in 1999. And and I should mention, some people know this, my daughter is actually a psychiatry resident now. So I'm kind of viewing psychiatry training again through her eyes. And yeah, when I was going through, psychedelics were something that had been falling out of favor from a time in the 60s and 70s when they were being used. I would not have predicted that 23 years later, we'd be back talking about psychedelics. And yeah, definitely a good example of something that seems to be evolving. Can I have one more?
Maybe an expansion of neurostimulation, so kind of broader use of things like TMS or vagal nerve stimulation, that kind of thing.
Yeah, I hear actually from Dr. Hassan that you can buy things on the internet that you can hook up to your head now. So yeah, I agree. I think there's going to probably be more of that. Probably people could think of other things like AI. I hear a lot about AI. I have a feeling that's going to become more important in psychiatry in ways we don't fully understand. But basically, the idea is that because medicine and psychiatry is constantly evolving, we do have to keep learning beyond what we're taught in our training. So when I was still a resident, we were being trained or taught using DSM-4. And of course, as you're all aware, there's an DSM-5, and it keeps evolving. What we define as different illnesses keeps evolving, the type of classification. This was actually, I don't know, maybe the people like Terry and Kathy will remember this, but at one point in the 90s in particular, there was this idea that people had forgotten memories, like lost memories of having been sexually abused as children. And this was a workbook that became a bit notorious, really, because it was for uncovering and it turns out in often many cases creating these memories of childhood sexual abuse and even satanic ritual abuse. Again, this was something that I remember one of my co-residents back in the 90s running into the clinic and saying, "Did you realize how many of our patients have been sexually abused in satanic rituals?" I'm like, really? I didn't know that. But these were, you know, seemed very real to us. And listening to Prozac when this first came out in the 90s, the Prozac was going to change everything. People were going to feel better than they'd ever felt before. And, you know, we now would have, I think, a much more realistic and guarded view of the power of Prozac. This is a local example from Dalhousie. Some people might recognize Dr. Kucher's name there, and there's other ones as well you may or may not recognize. And this is an article that was called the Dalhousie Serotonin Cocktail for Treatment-Resistant Major Depressive Disorder. So you can see that they were giving people, you know, pretty substantial doses of medications, including nifazodone, which isn't even on the market anymore. And, you know, probably giving them serotonin syndrome really was probably what this was, the serotonin syndrome cocktail. But again, if I was basing my decisions about how to treat depression on what I was taught when I was a resident by, you know, Dr. Devarajan and Dr. Durson, then this is probably what I'd be doing. So anyway, you probably get the idea. Things change, evidence changes, and not everything. I don't want to say that everything was discredited, but some things have been discredited, or there's more information now. So you're going to have to continue learning. And I'm sure most of you know this already. And it's useful to think about, like, what is going to be the way that you learn best? Because after you finish your formal training, staying current and up to date is going to fall really entirely to you. So are you somebody who likes to learn from courses? Are you somebody who likes to learn from reading articles or listening to podcasts? Thinking about that now and beginning to plan, well, what is your professional development going to look like? This is, some of you may have heard of Malcolm Knowles. So this is a very well-known education theorist who talked about adult education, which he called andragogy, and how it was separate from the instruction of children, which was called pedagogy. And the main idea is that if you compare the learning that you're doing now or that you'll be doing when you're in practice, it's different from when you would have been like in elementary school or even junior high, where you didn't get to choose what the curriculum was. You didn't really get to choose what time you learned or where you learned. Adults direct their own learning, and they tend to choose information that they think is relevant to their needs. And it often arises when there's some challenge that arises, something that comes up. So you see a patient and, so today in clinic, I was seeing a patient who is on lithium and aripiprazole and quetiapine, and they have tremor. And I think it's, probably the lithium, but I'm looking at the other meds. I'm doing a lit search. I'm trying to determine about tremor in these other with these other medications. So having problems that arise and looking up and reading around them is the way that adults learn, not just in medicine, but in other fields as well. We also bring our own experiences and knowledge. So we're not really usually blank slates in medicine when we're coming to a new topic. We have lots of clinical experience, prior training. We also have our preferences of how we like to learn. And when we can contribute to the design of our learning experiences, then that makes it particularly meaningful. So if you can set up experiences that are fulfilling your learning needs, that you have some control over when you do them or how you do them, that's probably going to be more rewarding for you. So there's other examples we could have done, but this is just, some of the things we've talked about before. In seniors' mental health, you'd have these sort of somebody who's 77-year-old with mild cognitive impairment, metastatic cancer, and now options of MAID, right? Which is something that, again, when I was training, MAID and now MAID for mental illness as well. Not something we would have had to consider. Cannabis, or as people have mentioned, psychedelics. Lots of changes. So I'm going to talk a little bit now about the maintenance of certification program. And sometimes when I've given a talk on this to senior residents, this is actually news to them. So I don't know if this is news to anybody or not. I won't ask specifically, but some people may not realize that in order to keep your FRCPC designation, you will need to do an annual update on what continuing professional development activities you've undertaken in the previous year. So, which may be a little bit disappointing because you thought, oh no, I got my FRCPC. I was done with having to record my learning activities. But the idea of the maintenance of certification program, and it is required to keep your FRCPC, and also provincial colleges, certainly Nova Scotia requires a statement of your activities in the previous year. I don't know if Newfoundland and other provinces do, but it's pretty standard. Yeah, pretty standard that provinces, the regulatory agencies, require evidence that you're continuing to keep yourself up to date. So the maintenance of certification program through the Royal College is it's very flexible, is the positive thing. It is based on really mostly on perceived needs. So when I ask you about things you need to know, so that example I gave of the patient with the tremor, I might think, okay, well, there's some things I need to know, look it up and feel good about coming up with an answer. What I may not realize is that there might be something going on, like with the patient or their medications, that I don't even know that I don't know, that you have an unperceived learning need. And those are more difficult. It can be hard to identify those. So the way that the maintenance of certification is set up is that Category 3 does involve some degree of feedback on your performance. And this can either be feedback from other people, like you would get in an annual meeting with your department head. It could be feedback on your activities, like your academic activities, like teaching. It can be self-tests that are built into the accreditation of some activities or simulation. And it can also be surveys that you do of your own practice. But basically, Category 3 is the chance for you to get some type of feedback on your performance and to use that to then subsequently design your subsequent learning. Whereas Categories 1 and 2 are very much driven by what you think is relevant and what you think is interesting. I'm going to talk about these a little bit more. So as I said, it's mandatory, and there's a minimum of 40 credits required per year and 400 over a 5-year cycle. I think if you have like mat leaves and different things, you can apply for an extension of the cycle. But you need to get at least 25 categories in each of the three, or credits in each of the 3 categories. And then you can obviously get more than that in some, because 3 times 25 would only be 75, and you need to get 400. Most of the credits are essentially based on time in some way. So if you attend the grand rounds in our department, that's an hour-long grand rounds, and it qualifies for 1 hour of category 1 large group or self-accredited group activities. Same thing if you're reading, like listening to podcasts, and a lot of those things are, and a lot of the feedback activities, it's how much time you spend in them. Which has, I guess, its pluses and minuses. There's some, question of whether sitting in grand rounds for an hour, half asleep is really, should count for a full hour, but that's essentially how it's structured. And yeah, there's, the most common ones are these activities, but there are some that are also related. You can get points for non-time based things, such as developing certain resources and so on. So this is just what I was saying about the, somebody want to put in the chat if you, I'm just looking at the chat, the good old days in Hazelton, yeah. Somebody just want to put in the chat, any residents want to put in the chat if they're already writing, like already entering their points in MoComp already as residents. Okay. Vincent says his, Tyson, yep. Amy, yep. Jessica, great, okay. Yeah, so there's a few people who've been doing it, and if you haven't been doing it and you want to do that, you can just go on the Royal College website and just make sure that you have the information. I think it's fairly straightforward for people to sign up for that. So as I mentioned, there's these 3 categories, and the first one is group learning. That includes things like conferences, grand rounds, and then some other small group learning experiences. It can be web-based, or it can be web-based or face-to-face. Some of these are accredited by, like, let's say the Canadian Psychiatric Association, or by a university like Dalhousie. Others of them can be self-accredited, so it is possible to do self-accreditation of like if you go out next year and you're working someplace and you're at a hospital and there's no grand rounds, but you would like to get together on a regular basis with some colleagues and do some studying together, learning together. It is possible for you to apply for group learning accreditation through the Royal College, and they have documents that explain how you can go about doing that. Category 2 is where a lot of just sort of self-learning activities and also unaccredited group activities, some of them fall in there as well. But if you're reading articles, or if you're listening to podcasts, you can record the points there. It's a good idea to keep some sort of a log maybe of what these activities have been. Just a comment about documentation. So for some of these activities, particularly category 1, the organization that has accredited them will usually send you or provide some way for you to verify your credits. But for some of these other things like self-learning and some of the category 3, it's mostly the honor system, to be perfectly honest. The people who are most likely to have to provide some evidence or proof of what they've done, I'm told, is if you miss the deadline. So these are all supposed to be submitted at the end of January every year. And I'm told that if you're late with submitting your credits, that's when you're more likely to have to provide proof of having, done different things. The other group I've been told, I don't know, but talking with some colleagues who graduated from outside of Canada, I've been told that they're more likely to be asked for, or at least in the past, they were more likely to be asked for supporting documentation. And then for the assessment section, as I said, these are activities that involve some feedback, and this can be things like simulation activities. This could be your annual meeting with your boss, or there are ways to do chart audits and other structured quality improvement projects that you can also count. And in those cases, again, I would say keep some documentation. Peer review is another one that falls into that category. Oh, so this is just kind of what I was already saying. For the category 1, it's 1-to-1 credits. So if you do an hour grand rounds, that's an hour credit, except for the non-accredited activities where it's actually less. Oh, and the other thing is that like there's sometimes like limits on how much you can claim in different categories. And then industry-sponsored events such as dinners usually cannot be claimed. But there are sometimes conferences and so on that have unrestricted grants, and those generally could be. And this, I talked a little bit about the self-learning systems, and there's a form that you could download from the Royal College website, which would allow you to keep track of the articles that you've read. So I think, that's a potentially useful thing to do. But again, there's a limit to how many points you can get in category 2. But there was a study that looked at where different specialists got their CPD credits for the Royal College MOCOM. And actually psychiatrists had a lot of category 2 points, interestingly. And then category 3 is actually counted 1 to 3. So if I spend an hour doing some sort of thing where I'm being assessed on my performance, like let's say it was a simulation activity that involved people observing how I interviewed patients and providing feedback so I can improve. These are actually credited on a 1 to 3 ratio. So 1 hour counts for 3 credits under the MOCOM points. This actually needs to be updated because they've changed the appearance of the what to call it, dashboard. But basically, there's a Royal College site. You have your login, you go in and you complete the different activities and store the points that way. So just a few points then about making the most of your continuing professional development activities. And then I think I'll turn it over to Terry for her exercise where we'll actually do some of this. The first is to develop habits of mind and practice to keep you up to date. And there's been studies done. I used to do some work for the college in Nova Scotia on the peer review program. And they've identified risk factors that put physicians, not psychiatrists specifically, but physicians at risk of becoming like subject to college complaints or successful college complaints. And sometimes people, they end up in a setting where they're in a private practice somewhere. They don't have colleagues. They're not really attending grand rounds. They don't have learners. So in that case, it becomes really necessary to put these structures in place yourself. If I'm here at Cobequid in a community mental health clinic, the nurses, if I start doing really strange things, the nurses will be like, Dr. Bascara doesn't use that anymore. Or, a medical student will come in and say, why are none of your patients on depots except for Haldol, or, whatever it is. But if you're on, you do need to think about, well, how am I going to set up some structures, whether it's attending a conference annually, receiving like the table of contents from journals, or actually subscribing to the journals, participating in small group studies and so forth. And so this is the same kind of thing, like just networking and taking on a role where you have interactions with your peers. Don't rely too much on self-assessment. So studies have shown that really as physicians, we're no better at self-assessment than other people in the general population. And often the things that we think we're good at are not, they're actually things we're not good at. We're very, capable of being confident about something that we're actually not competent at. So if you can build in some sort of peer review, even with your colleagues, or you could set up your own processes for tracking. Like, let's say you think, oh, I'm pretty good. I'm pretty sure that I check regularly, the lithium levels on my patients. You could go back and you could see, well, oh, look, it's been, 3 years since this patient had lithium blood work done. So you can go back and look at your own documents as well, and measurement and defining performance indicators for yourself that you want to track can be more useful than just having a global impression of how good you think you are at things. As I said, always enter your credits on time, because if you're late, you're more likely to be audited. And you can do CPD and activities beyond just medical expert, like leadership, teaching, becoming a better communicator. All of these are very legitimate. So maybe look to have sort of a mixture of different competencies that you're working on. So this, I think, is moving into the next part here. I don't know if these are actually your slides, Terry. Do they look like them, or are these still mine? I think maybe these are on your subject area. You're muted.
That does look like my slide. I made new ones, but just let me see the next few, whether I'll
Okay.
use them or not.
All right. Oh, time management. That's
No,
different.
that's you. That's you.
Okay. All right. You want me to talk about this first before what you do?
It's up to you, whatever you think.
Okay.
Ready to go whenever.
All right. And maybe I'll just briefly cover this. This is the transition to practice part that Terry's going to do, and she'll probably be talking about.
Yeah, maybe I just came in for a second. Maybe I did these 2 slides and then it went back to you.
Yeah, because it's this is really just sort of about time management and SMART goals. You want me to go?
So you want to talk about time management, just go by those other slides because I'll cover them again.
I'll cover them. Okay.
Yeah.
Yeah. So maybe I will just talk about time management. So people, I wonder if people are familiar with this. I can see a few people. Okay, Kathy's nodding. A few people nodding. So this is a grid, which I find really useful. And so Terry's going to be working with you now on setting up your self-learning program plan. And one of the things that can be really useful when you're trying to set something up like that is often self-learning for professional development ends up in the important non-urgent category until, of course, it's January the 29th, and then suddenly it's important and urgent. But before that, like this time of year, it probably seems kind of important to do the CPD, you know, you do want to be learning, but you've got all these things that need to be done that are more urgent. And one of the things about things that are urgent is they often feel important even if they're not. So if I was sitting here at the door or in my office and someone came to the door and knocked, I'd have to do something, right? At this moment, I might have to answer it or even deciding to ignore it because it's gotten my attention, so it's urgent. If I answer the door, it might turn out it's somebody asking if I can donate to the Cobequid Health Foundation. So it wasn't important, but it was urgent because it took me away from what I was doing. And while you're residents and once you're in practice, there will be a constant pressure to do things that are urgent that may or may not be important. And so when you're setting your goals in this next exercise you're about to do with Terry, think about how important does this seem? Hopefully it feels important. And how urgent does it seem? It may not feel very urgent. So you can think about, well, how am I going to set in accountability structures, which is what this next part is here, like where you figure out not just sort of whether you should do it and what you want to do, but how are you going to actually make sure that it happens? Sometimes having other people to keep you accountable, like maybe one of your coworkers or colleagues, could be an important way to sort of build in that accountability. Okay, so I'm going to turn it over to Terry because I think this next part is you. Should I stop sharing my screen and then?
Yeah. All right, so people can see my slides and hear me. Okay, so there is a reason this seminar is scheduled at this time, and that's because people who are in PGY6 are in transition to practice. So a number of people here are in that role, I'm thinking. I know Mackenzie's PGY5. I don't know if there's other PGY5s here as well. So people who are in PGY6 have to do things in this particular 3 months of their training that have to do with their continuing professional development. And the first is to write a professional development plan that you have to hand in to a mentor or your program director. So that's why I sent out that information. Has anybody done it already? Tyson, all right. I can't, if people could speak up because I can't see everybody's picture. Okay, so I think that's about it. And the other thing you have to do is register with Mainport, just like Dr. Hazelton was talking about. And you have to show some evidence that you're there. So maybe that little picture that Dr. Hazelton had up, that you've got a, that you're hooked up. So we're going to talk about the professional development plan today. Does everybody have the piece of paper? Yeah.
I just got a message that one person doesn't. So if anybody needs it right now, I can email you the paper. All right, I've got one email address. Okay.
And this is what it looks like. Yeah, so for the people this is what we use at Dalhousie. And so they probably have a different form at every university, but it's going to look exactly, very similar, because this is what we expect. And this is how it's outlined in the Royal College criteria for what your EPA should look like. So for this particular EPA, which is EPA Transition to Practice 2A, you have to pass something like this in. And I think we could get it together today in the next 20 minutes so that you're ready to go. So these are the kind of things we're going to be looking at. The first is a rationale for a learning plan. Why do you need one? So for most of you, you're in transition to practice. And for the PGY5s like Mackenzie and other people, you might still go through this process just thinking, what do I want to do in the last year of my subspecialty residency? How do I want to make the best of this? Are there certain things I'm going to focus on over the next year? And so someone already pointed out that they do have a specific job they are going to. So in that particular job, what are your clinical, academic, and research expectations? And, in the last 2 months, or when you're out in practice, are there things that you want to do to help you with that particular job? And so to start that process, the first step is self-reflection. So it was interesting that Dr. Hazelton said we're not great at identifying our own strengths or what we've done right, but part of the process is to do just that. So for example, I could say in the last few years of practice, I feel like I'm very competent at assessing psychiatric illnesses in older adults, and I'm really good with capacity assessments, but I don't know enough about addiction. And I've been in the position a few times where I find out my patient has addiction a few sessions in, and I'm saying, like, what was wrong with my assessment that I didn't tease that out earlier? So that would be an example of something I might say, I'm going to identify that as a need, and what am I going to do to make my practice better? And then the next step would be identifying these gaps, but also are there gaps in your training? So you've got 2 months left. Are you able to find it there? If you're not able to find it, where else do you have to go to find what you need? We talked about time management. I have seen that graph that Dr. Hazelton brought up, but every time it's there, it's like, oh yeah, I've got to rethink that. So just a good example of that is email. So I was just thinking today, you're doing something, you're working on a patient report, but you're still distracted by your email, and you're going off and answering things. And it's like, that could wait. If I did my email twice a day and did my answers, I would have more sustained time to do something. So just, how is it going to be? How are you going to make it important that you're going to do something about these gaps? And then the final is to write down exactly what is your plan. How are you going to do this? Are you going to do a literature review? Are you going to find a mentor who can help you in that area? Are you going to go to a conference, go to rounds? And what are you going to do in your, upcoming career to get you more? Like if you're worried about you're going to be working in long-term care, should you be spending more time there with a mentor or someone that can help you? Or you're going to be, in reality, talking to nurses that do that more than you do, and how are they going to help you? Making relationships with people so that when you're out there doing whatever you're going to be doing, you can call somebody and get information. So there we go. So let's just think about this, a rationale for learning. So I would ask, I'd like people to speak out loud, not even put it in the chat. So is there anybody out there who's thinking, yes, I am going to a specific place. What should I What should I be doing to get ready for that? And Amy, I'll put you on the block while other people are thinking about it.
I mean, one of the things I guess is neurostim, like ECT. I could use that as an example because I would, if potentially down the road I'm doing that as staff, then would need probably some more training in that. So doing a course in the fall to learn more about that.
That's right. That's right. So there is this University of Ottawa course that's usually in the spring, but this year it's moved to the fall. And it is a great course for people who are interested in ECT. So that would be a very good example of something you could do. What about you, Tyson? You've got your plan. You can tell us.
Yeah. So for me, it was related to my staff position. I'll be doing work at a long-term care facility. And so as part of the transition, just to be able to help facilitate and hopefully avoid placements or transfer to tertiary, I'll actually be doing my last block that I switched after doing the learning plan to working at one of the tertiary facilities that I have accessible here.
That's fantastic. And that's a great idea. You know, you've got 2 months left being with people who are specialists in the areas you're going to be working. So like make the use of it. I'm just going to pick a name now. Harry, are you in PGY6?
Yes, I am.
Yeah, what about you?
For me, the job that I mentioned earlier that I have lined up is outpatient in different settings, including clinics, rehab program, and long-term care facilities. But I think my learning needs will be kind of working with certain populations that are more acute, severe and persistent kind of populations that I may not work with in those settings. So
right,
kind of refreshing my knowledge about managing, acute psychosis or acute mania and neurostimulation, as mentioned before. Those
right.
topics may be helpful.
Yeah, so that sounds really good. So as we're going through this, you're going to be thinking, in the next 10 or 15 minutes, how exactly are you going to do that? What's your plan? So those are good examples. Oops, I got a hit on the screen here. So part of the next step is self-reflection. So you're going to have to write down some ideas. So a lot of us have good ideas about what our needs are, but what about our strengths? Do people feel confident enough to share some strengths they have? And we could start with Dr. Hickey, who's been practicing for a while. Do you have some strengths that you're happy to share with us?
So I'd like to say that I'm very organized and I'm very good with my time. And when the slide went on with the Eisenhower matrix, I just felt so excited and happy. But I'm now reading that book, The 7 Habits of Highly Effective People. And I've realized that people come first before schedules. So I'm trying to get rid of all the non-important urgent stuff. And I've actually got a special knock for the resident to knock on my door. So I know it's them and not somebody else who's gonna maybe take time that maybe shouldn't taking time from me.
Wow, that's a great, yeah.
But that's maybe too much information, but I would say that's what comes to mind.
Right. No, that's perfect. And that's a good example. So you shared with us not only your strength, but a need, right? Like, how do you filter through? And just like I shared it's such a good reminder to me when I saw that matrix too, stop answering email every 5 minutes. It just takes you away from everything else.
And TikTok is evil.
Yeah. Good examples. So what about Courtney? Would you be able to share a strength or an identified need? Is Courtney still with us? Oh, there's a few people gone. What about Amanda?
Sorry, yeah, it's not letting me change my name on here, but and my computer is dying, so I don't have my video on, so my apologies.
Okay.
But I think
hear you.
that I've been working on is reducing the amount of time that it takes for me to write my consult notes. So that's something I want to continue to work on as I'm getting closer to finishing.
That's a really fantastic one. I know one of the things I would do with my residents early on was just going over and helping them to think about the consult note. We get pretty good ideas about what the format is, but also with your follow-up notes, how to organize them. And if you're thinking the same way every time, it helps you just to slot in the information. But that is great. That's a really good thing to work on because it's going to help you be more efficient when you're out there as a staff. So it's a very good thing to work on and feeling comfortable. I know there's still, you still see people, residents, I'm not saying subspecialty residents, but, uncomfortable dictating. So they might sit and write everything out. And I'm like, okay, like there's no time for that when you're out in the real world. You can't be writing out your notes and then dictating. So you do have to get better at those skills. So I think that's a fantastic thing to work on. Anybody else want to share another identified need or strength? What about Kate? Kate, I know you're in child, if you're still with us. People come and they go. Okay. I got to see who's still here then. What about Catherine?
I definitely identify with Amanda's statement, sort of working on my consult notes and the speed at which I'm able to get them out, because I think sometimes I get stuck on sort of, it has to be perfect. And I think that actually can delay care, because really what needs to go out is the notes so that the family doctor, whoever I'm communicating to, can get started on things. And so sort of working on focusing on what the objective of the note is, and not necessarily meeting my own standards of perfection.
Yeah, those are really good points. And I think to me, there's always two reasons to write a note. One is for the treating physician, the PCP, who's taking care of them. And the other one is me, who goes back. And when you see the patient the next time, you want it to help you know exactly what you have to know when you're walking into the next visit. So you want a really good plan so that you know what you're following up on the next time. But yeah, those are really good examples. So next is sort of working time management into that. Whatever our plan is, we have to be able to find the time to do it, whether it's during the work day, and hopefully you can start to manage it that way, but sometimes you're doing some of these things at other times, or you're going to a conference that's away from work. But this is the last big thing, is the methods to achieve the personal learning plan. So Amy, I'll get you to talk about this, but I know you talked about and doing the ECT course. Could you give an example of anything else that you might do to help with that plan? Like talk to people, have a mentor?
Yeah, we have like people in our department who are nearly full-time focused on neurostim, so I could reach out to one of them to ask about opportunities for like applying the skills learned at the ECT course. So maybe participating in a day of ECT to try to apply what I've learned.
Yeah, that sounds good. Anyone else thinking about what they're going to do to meet their goals? What about you, Vincent? Have you been thinking about, are you PGY6?
I am. The
Yeah.
goal I had in mind was to stay updated with more, metabolic comorbidities, because our patients are so much comorbidity, and not treating it all the time, but most seeing it passing by. Sometimes you get, you forget what the exact guidelines are and what, the optimal treatment. And at times, I don't know how it is elsewhere in the country, but sometimes we're the only physician for our patients. So we got to stay aware and on top of that.
Yeah.
What I had in mind, I'm lucky enough to have on the inpatient unit, I'll be working a GP, so I'll have a lot of contact with them. But I'm also thinking about some conferences. Some of them are online, it's easier to attend. Some of them I haven't found some that are more local, kind of more. There's this Harvard conference, like general update for psychiatrists. Like there's a few of them passing around. And I think
Yeah.
of attending that one. I don't know if they're any good, but they seem to be meeting what I want.
Right. Yeah. No, sounds good. And was it the metabolic side effects to our medications, or just how people are doing in general in terms of their medical health?
Yeah, more in general medical health, right? And making sure I got the right guidelines when I see the right meds, and when I see something that's off, to make sure, be more confident in calling it out and like, this might be not an optimal choice, and not going into other people's turf, but just,
I
having
think
a
that's
holistic approach. Yeah.
Yeah, so important when a lot of people don't have a family physician anymore. And I think Dr. Hazelton had mentioned, doing lithium levels. So, I've been practicing for 20 years, and you're like, I'm always going to be on top of checking that lithium level. And so in my charts, I'd make up a piece of paper, and Amy, this will be a quality thing, but, so checking up on people's lithium, what's going on with their kidneys, keeping an eye on their creatinine. And then if they are on antipsychotics, where's their cholesterol? What's the ratio between the different? And so I have a piece of paper in my chart. It's a different color, so I'll pull it out, but I forget about it every once in a while. And you'd go too long before you do a lithium level. So it's like whatever you can do, and whether you're sharing it with other people, that you can remind each other, or have at your rounds once every 3 or 6 months, say, okay, did we check up on, how's everyone's lithium doing? Are you still doing that? Whatever it is to help you, to keep you practicing in a good way. So I think that's a fantastic idea. I've been to some of the Harvard courses, just general ones. They're very good. I see a few chats here. Right. Okay. So Harry said he went to a 2-line online course at Harvard. It was pretty good. Yeah. And Kathy says, if you use EMR, you can set reminders every 6 months. Oh, that's fantastic. Yeah, I didn't know that. So this is how we can learn from each other. That's great, Kathy. All right. So let's just see on the names. Dan, have we heard from you? What's your plan? Oh, you're PGY 5.
Yeah.
But still good to have a plan for your last year.
For sure, yeah. So I trained in Saskatchewan for my residency, and a lot of the PGY 3 during geriatrics was devoted more towards like acute care, well, whether it's CL or inpatients. And so coming to Queens here, I think it became very noticeable that I had deficits in terms of long-term care management and like home visits and things like that. So moving forward, I've just asked my program director, Dr. Hussein, to maybe for like outpatient rotations to slot me in with someone who does more long-term care and home visits versus just general outpatient clinics. Just to get more used to just learning by volumes, that's all. So.
Yeah, that's fantastic. And I think you'll find us program directors pretty flexible in terms of what you want to do with your electives. So I think that's great. So for people in PGY 5, making those changes is helpful. What about you, Harry?
Yeah, so for me, kind of opposite to Dan, because I know I already know what my practice will be. I've been doing like a 6 months of a long-term care outreach rotation just to prepare myself for those settings. I think for my learning needs going forward, I plan to meet up with my program director and a recent grad whom I have closer relationship with, so we can have like regular rounds to discuss cases and review literature on more acute presentations. So I'm kind of kept abreast with the acute management.
That's a fantastic idea. And Jessica, I don't think I've asked you yet.
Yeah, so I work with Dr. Hickey actually, and it's not official yet, but hopefully after I'm done, I'll join as staff here in the outpatient clinic. No, this is perfectly timed because there are, I think, a number of things that I need to put onto my learning plan in the last 2 months. One of the things that Dr. Hickey and I are doing together, I think there are certain psychotherapies that we don't get a lot of exposure to earlier on during our PGY 3 and 4 years, but would be really helpful for working with older adults. And so things like problem-solving therapy, that's something I've never done before. And Dr. Hickey has arranged an afternoon where we're going to have some learning around that. And I have a psychotherapy patient till the end of June. And then I think, just a few things of like learning to use Dragon. I'm a little behind with that because here at MUN, we don't do a lot of dictations, to be honest, and that's something that is lacking, but I'll get on that soon. And then just learning how to use the EMR effectively here, since I know what platform I'll be using. It's just sometimes things can be sped up if I know exactly how to use it, kind of going into the summer.
Yeah, so you have some good plans there, Jessica. Sounds good. And I think we've got Eric and Raheem. What about you, Eric?
Yeah, so as I mentioned at the beginning, so I'm in Prince George, Northern BC, and this is where I will be staying for practice. And one of the opportunities I had earlier in the year was to spend time in a different health authority in the province where there's already a very good working model of outreach to rural communities. And that's going to be an enormous part of what we're trying to pioneer basically here in Northern Health, where I am. And so that was really, really meaningful for building connections. I don't have many colleagues in Northern BC. And so to be able to really get myself grounded and have a network of individuals that I will be able to continue to connect with and really borrow a lot of the sort of models that are being successfully implemented elsewhere in the province that are similar to kind of what our rural sort of landscape looks like.
Yeah, that's fantastic. And building those networks is so important. I know in Nova Scotia, we have people in rural areas and they do spend, there's connections so you can talk about cases and stuff. So that's great. What about you, Raheem?
Yeah, so I'm working on a dementia unit right now, and we've had a plethora of plague ulcers lately that are kind of falling to me to manage, and my skills are not fresh. I haven't really touched that since PGY1. I'm trying to arrange an outpatient ID or wound care elective just to kind of get caught up on even identifying what's an infected ulcer, what isn't, and management strategies.
Yeah, that sounds like a good plan too. So Dr. Hazelton, as the expert in CBD or CPB, whatever, continuing professional development. I'm getting confused with CBME. Just are these the kind of things that you think are appropriate for planning? And
yeah, so I mean, they all sound like they're, so one of the slides I had up there that we didn't really talk about, but I think people are familiar with SMART goals, right? Stick your hands up if you know what I'm talking about, SMART goals. Yes, hopefully, I don't see every hand though. In case you're not sure what it is, so it stands for specific, measurable, action-oriented, realistic, and time-limited. And I think that just, some of you I'm hearing when you think this will happen, but again, back to the urgent, important aspects of these things, like somebody I think mentioned becoming, more conversant with, I think Amy, it was you maybe, with neurostimulation or something like that. And you were saying, there was a course she could take and maybe talk to some colleagues and that sort of thing. So to make it, I guess, more smart, it could be, well, what do I need to know about neurostimulation? Like, is it like I need to know how to titrate people who are receiving ECT, right unilateral ECT for the first time in terms of the threshold, like what is it you need to know? And measurable, like you'll be able to know, well, how many of these do I need to be able to do independently? I need to be able to do 5 independently to feel confident in this. And then your plan sounds great. So it is action oriented. You'll know if you've done it or not. Is it realistic? Like, I'm not sure, I missed when this course is that you're thinking of taking. I don't know if it's this summer or another year.
It's in the fall. Yeah.
It's in the fall. Yeah. So, if you've looked into how much it costs, sometimes this is a time of it's expensive for you, maybe starting. So is that the best plan? So just to kind of look at it and say, is it realistic? And then if you're going to take it, what's the registration deadline? when do you have to increase to the late fee? Maybe you want to set yourself a deadline if you're going to register by June 30th or whatever it is, if that's what your actual plan is. Sometimes putting that SMART framework on it, you kind of look at it and think, you know what, this is maybe, I do this. I look at it, I think, I thought this was a plan I had or a goal, but I think maybe this is more just a nice idea I have. So, and then it's like, well, if that's not quite the right goal, is there another one like that I think I could do that would be more realistic for me at this time? And then maybe that could be down the road. So I don't, that was the one thing I was thinking as Terry was asking questions, was that these all sound like good goals, but maybe just making them a bit smarter, particularly by putting deadlines on them and when you want to start and accomplish them might be helpful.
That's very helpful. All right. Well, Amy, I'll be expecting your plan. And Dr. Hazelton said she was happy to look at it as well,
Yeah,
as
for sure.
a housing mentor. And I hope everybody else is feeling comfortable with the process and that you can get this done. Thanks for your time. You're muted, Kathy.
I want to extend a hearty thank you to Dr. Hazelton and Dr. Chisholm. I really appreciated this very useful and lighthearted session. I learned lots. I'll keep coming. And Lara, we're going to ask you to do 90 minutes next year. I hope that's okay.
Sure.
All right. I'm going to send some feedback emails to the residents, and everyone have a great day. And we'll see y'all next month.
Take care. Bye now.
Bye.